while we're waiting to transition to the next conversation, I want to embarrass someone else in the audience. I see a lot of you who, as part of our law school education, take on students and for fellowships and for independent projects. And WellSense has developed a fellowship program, Boston Medical Health Plan, and they have taken on one of our law grads, Amanda Ramirez, who is here today in a 2-year fellowship learning about Medicaid. And I see the DRC and Planned Parenthood and New Hampshire Legal Assistance and the Insurance Department and a number of others who take on our students, and it is much appreciated. So if our next panelists want to come up, I will introduce you in a minute, but if you want to sit down, you get to listen to me talk a little bit. We have another audience participation exercise, okay? So everyone take out a card, and we have 2 questions for you to be thinking about while we talk more about value-based payment. And the first is, what is one way you think Medicaid in New Hampshire can improve value to its members? That's the positive question. And then it is, what do you see as the most significant barrier to improvement? That's the next question. So think about those as we talk. I'm just going to briefly introduce who is up here and then warn you that they have to sit and listen to me for about 20 minutes, talk about value-based purchasing in New Hampshire. We have Barbara Crowley, a pediatrician for many years, who is the Chief Transformation Officer at Maine General Health. So she's here from Maine. Welcome, Dr. Crowley. Kevin Stone, who many of you may know, who is a senior consultant and principal with Helms & Co., and also the chair of the board of Vermont OneCare, which is a multi-provider, multi-payer ACO that is mostly Vermont but also crosses over a little bit. And Stephanie Brown, who hails from Massachusetts, who's the director of the Office of Behavioral Health for Mass Medicaid. And we're very lucky to have these wonderful panelists, each of whom, after I speak, are going to give a brief presentation about the value-based developments in their Medicaid program in their state, what their experience has been, and a little bit of commentary. And then we're going to open up to all of you for a question and answer session around value-based purchasing. So I wanted to just let you know that I'm going to talk a little bit about today's landscape and what we're doing in New Hampshire, but I'm not going to be answering the question as to where our Medicaid program is going. So this is a process. This is part of our learning experience together, where we're going to really think about New Hampshire, think about all the information we learned this morning around the New Hampshire Medicaid program, and think about what else is going on in our state that we are doing well. We do many things very well in our state. Again, one of them we do well is all come together to try and tackle what is a very difficult problem as we go forward, which is, what does paying for value mean in Medicaid? What does that really mean? What do we want to accomplish as we move towards a system that pays for value? What I'm focusing on today is what are some of the guidance that we just received from Diane Hasselman, which is, what are other non-Medicaid purchasers and payers in the state doing regarding value-based purchasing? And are there opportunities for alignment? And how ready is the provider community, which many of you are, to accept risk and reward without negatively impacting access to care? Because that's a critical question to ask as we delve into this. And what can we learn from our neighboring states? And remember, as we talk about our neighboring states, you have a cheat sheet in your folders about each one of our neighboring states, and what they do and what their population is and what percentage of their budget they spend on Medicaid, and what their waivers are, et cetera, just so we can get a little bit of a sense. So a reminder, what do we mean by value-based payment? I think we all mean very many different things. I think we were reminded briefly that what we mean by value is that we're getting quality at a low cost, so that we're providing high quality, efficient care. I think many in the Medicaid program think they are providing very efficient care. The question is, are we doing it as part of a larger system, taking care of the whole patient, and are we achieving outcomes that we can demonstrate that are tied to cost savings? And that's often the little pitch at the end that goes with value-based purchasing that we don't necessarily like to talk about. What we're trying to do is demonstrate that for the value spent, we're purchasing the triple aim. that we are, the experience of care, population health is at the most efficient per capita cost. And I think I was reminded by my colleagues to add the fourth of the triple aims, which is to make sure our providers are surviving another day in this environment. So this is just a quick slide to demonstrate that when we're talking about value-based payment, we're talking about trying to have us all together achieve value for the patient and for the patient care. And we talk about practice transformation and innovation and payment reform all in our various silos and all in our various ways. But value-based payment is the goal that Medicare and now Medicaid are setting forth for us. Alternative payment models are a way to get at that goal. They're a mechanism to pay for the value. So that's when we say APM, alternative payment models, that's what we mean. That is the different way to pay to get to value. So what are other states and other payers and other providers in the state doing around APMs? Leveraging investments are so critical, especially in the small state that we are. Are enough other payers participating in this model or aligned with the proposals that we might come up with, that there's a strong business case and a supportive business relationship for providers to participate? That's an important question. And we also have to analyze ourselves as providers as we enter into this conversation. Some of the providers in the room are almost exclusively Medicaid providers. Some of them are diverse and hail from resources from many payers. And that's an important thing to remember. Who are you? And what do you plan to do? And can you leverage the innovation that you are achieving across different payer types, both for survival and then also to make it work demonstrably across different populations? This is a great slide from our Consumer Union Healthcare Value Hub from Lynn Quincy, who came to town and talked to all of us. That little green spot over there is fee-for-service. That's where we are. We pay for payment. I'm just going to move this back so you guys can see the panel. Fee-for-service, we pay for things a lot, right? And then what we're trying to achieve is moving to the total cost of care paradigm, where you're moving away from a fee-for-service environment and you're moving towards a total cost of care paying for the value. And this slide just shows you it takes a while to get there. It doesn't happen overnight. There are not lots of various stages and shades as you get there towards this concept of total cost of care, total capitation. And as Diane showed us, Medicaid is sort of in that first planning stage of paying for quality. The ultimate goal will be transitioning to total cost of care. Many of our providers, for example, the mental health centers, have what you could call risk contracts. The question is, are they going to move to that phase where they're really value-based as opposed to fee-for-service based underneath? So let's talk a little bit about New Hampshire, our favorite place. Again, just a little bit about how we're covered in New Hampshire. If we're going to talk about whether we're leveraging other payers, how are we covered? We've heard that we have about 1.3 plus million people in New Hampshire. About 187,000 are on Medicaid, including 53,000 in the New Hampshire Health Protection Program, and 134,000 who are in New Hampshire MCOs. Then we have our marketplace, and we talked a little bit this morning about the two different plans on the marketplace. Healthcare.gov and New Hampshire Health Protection are almost even in terms of their allocation in the marketplace. 57% of individuals in New Hampshire are covered through employer group plans only for 2015. And I just want to say that the New Hampshire Insurance Department does an amazing job collecting information, and one is our real source for information about how we're covered and what's happening in our insurance markets. And some of this information is pulled from that. We also have about 125,000 covered by our state or local government plans. They are a large purchaser as well. And about 6.3% are left uninsured in our state, down from 11% in 2009. This is another way to look at our coverage and where we actually get coverage in the state of New Hampshire. So what's happening in New Hampshire? This is an attempt, and I will say that some of the brainstorm behind this is discussions with Patrick Miller over here around how to categorize the different APMs in the state. Global payments and accountable care. That is one way to organize for alternative payment models. We have ACOs, accountable care organizations. We have some bundled payments. And as you saw from Joe's slides, it's not surprising that most of the bundled payments are around surgery and orthopedics because that's a high cost driver in the commercial and Medicare markets. So that's where we see our bundled payments in New Hampshire, mostly retrospective. And then case rates and capitation, where you set a total medical cost. Then we have practice transformation, a lot of work, which we'll talk about in practice transformation with MIPS and primary care enhancements on the commercial side, medical homes, and other pay-for-performance options. And then we have something we love to talk about, which we refer to as collaborative care, which takes on many different meanings depending on who you're talking about. But really in New Hampshire, our collaborative care effort focuses on integrated behavioral health. Are we going to actually pay for enhanced case management or care management tied to payments to affect a new outcome? What additional interventions are we going to purchase in a certain care environment that we think are going to bring about transforming care and lowering cost? And we have the DSRIP waiver, and our efforts there fall in that category as well. So it's important, I think, as we talk about insurance and payment reform, because payment reform does go hand in hand with the payer who are paying for it, whoever that might be, is that we also have simultaneously value-based insurance design. So the plans that we are working with and the plans we are being paid for by are also working on value-based insurance design. That's slightly different. They need to go hand in hand. Oftentimes providers have no idea what the value-based insurance design is for the plan they're working with, none. And certainly the consumers don't always know either. Network strategies, formulary designs, okay? Tiers and copays, how are they structured? What are they driving for their outcomes? Reference pricing, are they using reference pricing with different providers? Centers of excellence, are they steering patients to certain centers of excellence? Narrow networks, is that a tool they're using to drive care and improve cost and quality? Wellness incentives falls in another category around insurance design. Promoting wellness, incentivizing prevention and preventative care. Are you incentivizing folks to go to the preventative care without a copay, to get family planning services without a copay, et cetera, in order to drive your total cost and your quality? Consumer engagement tools, we all know what those are. Pricing tools, are you helping people go to lower cost providers? Low-cost provider options within the plan. Do they exist at all? Are there patients being driven there? Telemedicine. And then high deductible plans and how they're being used. So that's just an important distinction to make. Let's talk a little bit about what Medicare is doing. And we have some of our wonderful folks from the Citizens Health Initiative, Northern New England Practice Transformation Network, and many participants here today. We know Medicare is going towards goals. 50% by the end of 2018 are supposed to be in alternative payment models. The payments are supposed to be flowing to providers through alternative payment models. On top of that, 90% are supposed to be flowing through payments that are tied to quality. So pretty robust goals in the Medicare side. A lot of the transformation in Medicare is focusing on primary care and other professional services, but mostly primary care. Let's look a little bit about New Hampshire. Who are we with regard to primary care? And I know there's some real comments that want to be made about workforce development here. We have between 1,500 to 1,800 active primary care physicians in New Hampshire. And as of July 2015, about 477 PCPs and NPs achieved patient-centered medical home recognition. It was a real initiative in New Hampshire, a core group across a whole multi-sector practice at CHI really worked on the patient-centered medical home, 21 organizations and 82 sites. We have 11 federally qualified health centers. I think you heard Diane talk about it. We know who we are. Federally qualified health centers are a real constant regional presence in New Hampshire throughout. 14 rural health centers as well. We're a rural state, and several additional health clinics that fall in that category. We have 20 clinic sites for family planning, 5 Planned Parenthood clinics, which serve over 50% of the family planning patients in New Hampshire. Do we have electronic medical records, which is something we definitely need to do any of this? We do. There's a good, robust use of electronic medical records in New Hampshire. Almost all the CMHCs, FQHCs, and hospitals have electronic medical records. That's not to say they all work or correspond with each other or have interoperability or meet the needs for various things, but they do exist. So just briefly, we do have a large number of our practices participating and looking towards transformation in Medicare in order to get to that pay for performance that MIPS is mandating. So Medicare is requiring it. Our practices are cooperating. We have and are working on Northern New England Practice Transformation Network. I see Jean Ryer up there, who is leading that charge in New Hampshire. It's a multi-state. We have 174 practices who are enrolled in this transformation process, working towards transformation, 849 providers. So our providers have taken notice since Medicare has said we're going to change the way we pay you. And it's not happening in a couple years. It's happening very soon that Medicare is going to be penalizing providers if they do not meet their objectives under this criteria. Hold on, my slide isn't changing. There we go. So I'm going to talk a little bit about our Medicare accountable care organizations, which I think Kevin is going to go into and Dr. Crowley is going to go into as well. Who do we have in New Hampshire that's organized as accountable care organizations? It's an ACA product. Remember that an accountable care organization is an organization that is organized around providers to transform care. The ACO is the organization itself. Okay, Medicare has been trying to figure out, okay, now that we've said we want accountable care organizations, how are we going to pay them? They've tried a couple different experiments on how to pay them, not all of which have worked very well. But we have a couple in New Hampshire. I'm just going to highlight them very briefly. The Dartmouth-Hitchcock Health Next Generation ACO. This is a new form of ACO, and it's being paid a new way as a next generation ACO. It's got Dartmouth-Hitchcock and a number of the Hitchcock clinics, Concord, Keene, Bedford, Nashua, and a number of skilled nursing facilities in that ACO. Enrollment for attributed lives for 2014 for Medicare. Remember, this is a Medicare ACO, 22,607. I included some wonderful data from the Hospital Association, not because these are Medicaid ACOs, but just to give us a sense of where the hospital that are leading in these ACOs, what percentage of Medicaid they treat, just to give us a frame of reference. And DMHC's net Medicaid revenue represents 28.4% of reported total Medicaid net revenue by New Hampshire hospitals for 2015. New Hampshire Accountable Care Partners is another ACO, Medicare ACO we have in the state. It's a Medicare shared savings plan, and it only is able to achieve upside risk and share savings. 6 hospitals participate in New Hampshire: Concord, Catholic Medical Center, Wentworth Douglas, which is now an MGH affiliate, Elliott Health Systems, Exeter Health Resources, Southern New Hampshire Health System. Midstate is an FQHC who's part of it, as well as Riverbend and Concord VNA. So 55,000 Medicare attributed lives in the New Hampshire Accountable Care Partners ACO, and it represents these hospitals collectively. Again, it is not a Medicaid ACO, but these hospitals do represent 37.4% of total reported Medicaid net revenue for 2015 for hospitals. And then we have our New Hampshire Rural ACO, which is yet another variation, which is an advanced payment ACO, which is for rural providers. It is also a new ACO, replaced in a prior existing ACO, and I think Ed Shayla talked about this. They represent, they have the participation of AVH, most of the North Country hospitals, Androscoggin Valley Hospital, Weeks, Upper Connecticut Valley, Littleton, Cottage, and then a couple FQHCs, Coos County, Indian Stream, Ammonoosuc, and they represent 11,788 attributed lives. For a total of the hospitals involved, 9% of the total Medicaid net revenue by New Hampshire hospitals. for 2015. So that's sort of our ACO on the Medicare side picture, just so we know. And on the commercial side, let's quickly take a snapshot. And this is, again, from the New Hampshire Insurance Department's information. What I'm showing you here is in our commercial market, and by commercial market I mean our group plans and our individual plans. Yes, Tyler, that's who I'm talking about. So I have on one side the fully insured members in risk contracts and the other self-insured members. And remember that we have a large number of employers who self-insure their own covered lives, their employees. So we have to talk differently because they're regulated differently. And this shows you the red side is actually providers who take on, or members that are covered by plans where providers take on full risk. And they take upside and downside risk. That means the providers are penalized if they don't achieve quality or usually cost outcomes. So a lot of the commercial side, it is quality driven, but it's also cost driven. So 11% in 11 and only 14% in 2015 were taking upside and downside. And you see a similar type, only a slight shift on the self-insured side. However, large increase in number of providers for the blue category who are taking upside risk now in the commercial markets. We talked briefly, and we had Stephanie from Harvard Pilgrim Healthcare who talked briefly about some of the innovations. You know, as we talk about value-based payment reform, it becomes blatantly obvious almost immediately that if providers move towards a system where they're improving quality and doing more, providing new services or innovative services or added interventions and getting paid less or reducing the cost of care, they're going to want to be able to have some part of that. So we have a couple collaborations going on in New Hampshire on the commercial side that really do try and tackle that issue and align payers with providers. Benevera Health is an alignment around a care management structure where they're actually sharing in the risk from the revenues of the Harvard Pilgrim plans across the plans, and it's a joint venture that's focusing on practice-based care managers with high-need patients. So do I have anyone left from Harvard Pilgrim in the room? I just want to make sure I'm getting this completely correct. Yeah, so they're really focusing on high-need patients across the plans and connecting care managers with the high-need patients and with social services in the community for those patients. Tufts Freedom Plan, different model. It's a joint venture around an actual insurance plan. They are an insurance plan. It's a new insurance plan, and there's joint ownership of the insurance plan with many of the hospitals I mentioned before in a Medicare ACO, Catholic Medical Center, Concord, LRGH, Southern New Hampshire Health, Wentworth Douglas, MGH, which is an MGH affiliate. And they are focusing on practice-centered care management as well. So they're also using the data that they can accumulate and look at together to really focus on high-risk patients and where the needs are most. So Benevera has about 35,000 enrollees, and Tufts has about 16,500, but they came on the market in 1116. And then we have our collaborative care efforts. We really are looking at behavioral health integration for a Citizens Health Initiative and rate-based MCO contracts. How can we bring some collaborative care and managed care and risk-based care to our behavioral health, but work within the system that has worked up and been built up over many years, directed to the seriously mentally ill, and then also the care for people with what seem to be ever-increasing behavioral health needs in our state. That's what our DSRIP waiver is focused on, and Deb gave us a wonderful blueprint for how the state is going to leverage its project with regard to the DSRIP waiver, which is truly innovative, and how they're going to bring about some payment reform through that goal, because that is the goal of the DSRIP, is that at the end, Deb, and if I might be so bold as to just confirm what you said, which is at the end of the day with the DSRIP, their goal is to move provider payments to 50% payment reform models, and the DSRIP is the vehicle to talk about and think about and manage that transition. And so there are a number of projects that are looking at how to do that and how to make that happen through the DSRIP. So hurdles, I think I have about 2 minutes to talk about the hurdles. I put this at the end so as not to depress us too much, but It ain't easy. What are the key hurdles that get us towards alternative payment models? We got some regulation. I don't know if anyone realized that we regulate our healthcare industry. But we got some significant regulation on the way we just make payments and reimbursements. I mean, the Medicare criteria for getting paid, I don't know if there are any PT therapists in the room, they're just voluminous. They're really staggering what you have to do around even where you keep your medical records and who's licensed by whom and how you submit your bills and who supervises who in order to get paid for Medicare. We've got fraud and abuse regulations. Just note to self, it's a criminal offense to give anybody any benefit in exchange for a referral of a Medicaid or Medicare service. And there's only certain exceptions to that basic rule. And those are really critical. Most of our healthcare industry is formulated and structured around exceptions to the fraud and abuse laws and rules. So they are critical in our conversation. Federal and state privacy law regulations. I know we're all grappling with that. We all want data, we want information, but guess what? Health information is confidential. So you got to make sure you can share it correctly. Antitrust laws and general regulation of healthcare entities by charitable trusts. Antitrust laws really try and prevent providers from coming together to influence prices. So you got to know what you're doing if you're going to come together to talk about how you're going to price your product together. Professional responsibility, licensing, and ethics. At the end of the day, our providers are the ones who are still responsible for any harm in the healthcare industry. They carry it with their license, they carry it with their malpractice risk, and so they care how you restructure their payment if they're going to be penalized and have to comply with benefits that restructure their behavior. So make sure you include your providers, your licensed professionals in the decision making as you come to new innovations. Fee-for-service infrastructure, misaligned motivations and incentives. We've talked a little bit about that. We've got to get them aligned to achieve the outcomes here. The risk of financial loss is huge, especially for our access providers. Access to data information. And we also have a real lack of a centralized information source regarding healthcare delivery in the state of New Hampshire and payment, how it's done. So that's in a nutshell the barriers. I'm sure we could talk a lot more about what they are as we came up with them. I just want to let you know we have these states' information in your packet, so we can look a little bit about what they're doing and who they are and what their populations are as compared to New Hampshire when we're talking about how they organize. They are moving forward, as Diane said, states are moving forward with value-based payment in Medicaid. And so we have a lot to learn from what the other states are doing and a chance to ask them questions. Maine is focused on accountable communities and patient-centered medical homes. Massachusetts has focused on accountable care organizations and other type payment reform models. New Hampshire, we have our DSRIP and integrated delivery networks. Rhode Island, broad spectrum of APMs, but also ACO focused. And Vermont is an all-payer transformation, head-to-toe model. So we're going to actually reflect on what some of our neighboring states are doing and understand that the next phase in New Hampshire is to figure out where we're going and to have our continuing conversation together and with our amazing Medicaid program and director about where New Hampshire's going with transformation in Medicaid reform.